When there is bronchodilation, it is the sympathetic system. When you are under the influence of sympathetic system, you need to dilate your bronchus, you need more and more, you have to run, you are in stress, so bronchus will dilate. It will decrease airway resistance. Okay? And the receptor which is there is beta 2. Beta 2. It is acting on which receptor, doctor? Beta 2. That is why in asthma we give beta 2 agonist like salbutamol. We can also give nitric oxide and VIP. They are non-adrenergic, non-cholinergic agent which can cause bronchodilation. So these are causing bronchodilation. So when you are under sympathetic stress, bronchus will dilate, so you can cope up with the stress, and the receptor present in the bronchus is called as beta 2. That is why we give beta 2 agonist. Now, bronchoconstriction is under parasympathetic system. So it will increase the resistance. An example is acetylcholine. Acetylcholine. What is the pharmacological agonist of acetylcholine? Methacholine. These can cause bronchoconstriction because you are relaxed. You don't want much air, not that much. So bronchus are relaxed. So that is why in asthma we want dilation. So we will give anticholinergic like ipratropium bromide. It can cause bronchodilation. We can also give histamine, antihistaminic, because histamines can cause bronchoconstriction. So if you give fexofenadine, if you give citrogene, it can cause a bit of dilatation. Then leukotrienes are most potent bronchoconstrictor. Remember that. Among all these, acetylcholine, histamine, who is the most potent? Answer is leukotrienes. So leukotrienes are the most potent bronchoconstrictor. Now respiratory airway. Till now I have discussed about the conducting airway. Now about the respiratory airway. There are two types of cell, type 1 cell and type 2 cell. Type 1 cells are mainly for exchange of gases. They have large surface area. They cause fluid transport via Cooperin 5. And type 2 are surfactant producer. They have progenitor stem cells to produce type 1 also. Type 2 can produce type 1 also. They are also called as granular cells. Now we will discuss about the surfactant which is produced by type 2 pneumocyte. It appears from 28th week to 32 week of gestational age in amniotic fluid. It is a lipoprotein. It is a lipoprotein. It has lipid also and a protein also. The name of lipid is dipalmitoyl phosphatidylcholine, also called as lecithin. Second is sphingomyelin. And the ratio of L by S should be more than 2. Only then lungs are mature. If ratio is less than 2, lungs are immature. They can have hyaline membrane disease. About the proteins, there are four types of protein, A, B, C, D. A and D are important for innate immunity. We have innate immunity in the lungs, and this is because of surfactant protein A and D. Regarding B and C, they form film of surfactant. The surfactant is produced, but they are not decorated. So who is decorating the film in the alveoli? Answer will be surfactant protein B and C. A and D are for immunity. Some people had COVID, a lot of people have, some people survive, some don't, because they have different immunity. And this immunity is provided to the lung by surfactant protein A and D. Is this clear? And if someone is cigarette smoking, they will be destroyed. That is why those who are smoking the cigarette, immunity become very, very less. They are very, very prone for infection. And which protein is involved? Surfactant protein A and D. You can see here it is a type 2 pneumocyte. Type 2 pneumocytes. Now they are produced in the form of lamellar bodies. They are dense, compact lamellar bodies. They are secreted in the form of, if they ask you how they are secreted, so you can write it is secreted in the form of tubular myelin, and then they are decorated in the innermost layer of alveoli. Can you see this decoration? This wonderful decoration of surfactant monofilm. Okay, this is surfactant monofilm, and this decoration is done by type B and C, surfactant protein type B and C. Now sometimes they ask you, they will give the image and they ask you what is this. You can see these compact dense bodies are actually lamellar bodies. They are dense compact bodies called as LB. That is why to see the maturity of lung we do LB count. It is LB. What is LB? Lamellar bodies, and these thin structure they are actually tubular myelin. So surfactant is produced in the form of lamellar bodies, secreted in the form of tubular myelin, and decorated in the form of monofilm with the help of surfactant protein type B and C. Is this clear? What is the function of surfactant? It decreases surface tension, thus prevent collapse of alveoli. It decreases collapsing pressure, okay, by breaking water structure in the alveoli. It also increases the surface area, okay, so that there can be more gas exchange. It also decreases work done. It also decreases work done. It prevents pulmonary edema. And if there is absence of surfactant, it causes respiratory distress syndrome. Okay. Now, what are the factors that increase surfactant and what are the factors that decrease surfactant? Beta-methasone and dexamethasone both are steroids. So they can increase surfactant. That is why those who are having premature baby, okay, we will give dexamethasone to the mother so that surfactant produced can increase. But dexa is not better. Which is better? Beta-methasone. Beta and dexa both can be given, but dexa is better. Then T3 and T4, thyroid hormones are also involved in formation of surfactant. So if someone is hypothyroid, surfactant production will be less. Now, insulin will decrease surfactant. So those fetus whose mother are diabetic or they have gestational diabetes mellitus, they have insulin resistance. What is insulin resistance? Normal amount of insulin doing subnormal action. So they will increase. In type 2 diabetes, insulin become more because they are not acting properly. So more insulin can decrease surfactant. Okay, treatment is surfactant, of course. One very important point, smooth muscles are maximum relative to the wall thickness where? In the terminal bronchiole. Sometimes they ask you this question in the Viva. Coming to the mechanics of breathing, see, Boyle's law says PV equal to nRT, P is proportional to 1 by V. If you increase volume, pressure will decrease. This is important for understanding of intra-alveolar pressure. Intra-alveolar pressure at rest is 0 mmHg. During inspiration, volume increases, so pressure decreases to -1. At the end of, again it becomes 0. During expiration it is +1. At the end 0. It is also called as intrapulmonary pressure. You can see here. So it is intra-alveolar pressure. So during inspiration it is -1. During expiration it is +1. You can see here. It is called as intra-alveolar pressure. Inspiration, volume increasing, pressure decreasing -1. Expiration, volume decreasing, pressure will increase. It is called as intra-alveolar pressure. The first one is actually intra-alveolar pressure, and second one is intrapleural pressure. Intrapleural pressure, you can see it is always negative. You can see when you inspire it become more negative. So intrapleural pressure is the pressure in the pleural space and it is always negative. What is the reason? I will tell you now. At the resting condition, intrapleural pressure is -2.5 mmHg. Also, if you convert it into centimeter of water, it becomes -3.4. Okay, this is the conversion ratio. It is always negative except forceful expiration. Only when you expire forcefully, this is the only condition when it can become slightly positive. Why it is always negative? Because number one, opposite recoiling of lung and thorax. I will ask you a question. If you cut the pleural membrane, your lung is going to collapse. Thorax are going to expand. This is the basic nature of your respiratory system. Lung want to collapse, thorax want to expand. So intrapleural pressure will be negative. And second is lymphatic drainage. Because of lymphatic drainage, intrapleural pressure is negative.